everyone. Welcome to our It Takes a Village series. I'm Dr. Carrie.
I'm Dr. Michelle.
And I'm Margaret Stoch.
Welcome, Margaret. Tell us kind of what you do.
Thank you. Thank you so much for having me. I am a speech language pathologist and orofacial myologist. I specialize in working with infants and children with swallowing, feeding, and myofunctional disorders.
Okay. So delve in, what is the thing with tongue ties? Why don't we want our kids to have them? What are the implications?
Definitely tongue ties and everything related to that. It has been a hot topic lately, and the most important thing that parents need to remember is not just about what the tie of the tongue or the tie of the lip looks like, but it's important that we assess what functional implication that restriction in the face or in the mouth has on things that we do every day, such as breathing, chewing, swallowing, and then for older kids in adult speech. So,
okay.
I know some of the things that we'll see is whether it's infants or even school-aged kids is, one, if they had issues with nursing, or maybe they didn't have issues with nursing, but maybe they're a really picky eater and there's some of the sensory stuff going on orally, or maybe they're not very well rested and they're having issues focusing, and just knowing how really intimately involved every part of the body is, including the tongue, because we know that attaches to the cranium, and then that's attached to the neck and everything else. So
And you have 5 cranial nerves that run to the tongue. So there's a lot of input and sensory stuff going into that area.
yeah. So not only the cranial nerve intervention in the tongue and in the whole face that is important to remember, but also the muscles. So the tongue in itself is composed of 8 muscle groups. So there are 16 muscles in the tongue in itself that have to work separate yet together to complete the functions that we need to have the tongue done. So for speech and swallowing and breathing, most importantly. So there's just a lot of things that kind of we have to consider when it comes to the function of the tongue, and it's not just one muscle. There's different muscle groups that we have to address for different things.
So what kind of stuff would you do for a baby or a child that comes in? What's kind of your protocol? Do you do exercises, or what does that entail?
So for a baby that is having hard time nursing, we will complete a functional assessment, either rule out or confirm that there is a restriction, such as a tongue tie or a lip tie, and releasing that is just a drop in the ocean of the overall function of the baby and the overall treatment protocol. So we will definitely work on getting the baby ready, getting the parents ready for the release, but also we look at how the muscles are functioning. So we will do exercises that the parents are doing with the baby. Typically the protocol is 3 times a day, just kind of depending on what we're targeting, then that kind of varies in what the exercises are for that baby. Definitely after we confirm that there's a tongue tie and we go through the release process, then afterwards we need therapy to have the baby learn and establish new functional patterns for breathing and sucking for the baby, for either is using the breast or the bottle, and making sure that we are on the right track as far as oral motor skills development that are preceding later skills such as chewing and acceptance of solid foods, and then later speech. So we look at what we call feeding skills.
Okay. Yeah.
we hear a lot about, sorry, I didn't want to interrupt you.
Go for it.
I was like, man, there's just so much we can talk about. But myofunctional training, we hear that sporadically, and if you could just let everyone know what that is, how it ties into it. Do all speech language pathologists do like what you do, or is that?
So the areas where a speech pathologist can't work is very broad. So what we as a profession can do is very broad, and there isn't a single speech pathologist that knows it all. And it does take that postgraduate training to get that skill, to be considered an expert or to be considered a specialist in that particular area. So for myofunctional therapy, there are different courses and different trainings that you can take, but the gold standard for myofunctional therapy as of right now is what it's called Certified Orofacial Myologist, and that is presented or given by the IOM, which is the International Academy of Myofunctional Myofunctional Therapy, and it's a very I would want to say strict course that you have to go through, and then you're granted that certification, and then it also involves you maintaining that, so you have to continue to get courses to be able to maintain that certification. But there are certainly speech pathologists out there that go and get myofunctional training with other organizations. When you're seeking out myofunctional therapists, just make sure that you do your research and then you ask about their background and their experience. It's just one class over the weekend is not gonna be enough for that person to understand the orofacial complex and understand, especially for infant feeding, as there's so much more that can be contributing to issues with breastfeeding or the baby's functioning that is not related to a tongue tie or lip tie.
And then, and kind of you talked to us before about it's not just releasing that tongue tie. There's a lot of stuff neurologically and musculoskeletally to kind of retrain in the baby or the young child, because if you think about it, that baby is swallowing in utero, like when they're still in the womb. So you really kind of need to retrain the brain, tongue, body connection to make sure we make those lasting effects. Exactly, yeah. So baby starts to swallow amniotic fluid at about 20 to 22 weeks. And we think about all this training that they already have by the time they're born. So there is a tie, that tie has already been there in utero, and this baby is trying to compensate and figure out ways of how to function with whatever structure that baby has. So by the time this baby is born, we already have developed compensations in functional skills, which then need to be retrained after the release is done.
So technically, a lot of these babies are coming into the world and they have chronic conditions already, because usually by definition anything over 8 weeks is considered chronic. And if there is like a pattern disrupt in utero, that starts to set the stage. And I'd be curious if you have someone that says, well, we didn't have nursing issues. They speak pretty well. We're not worried about speech. What would be the implications, like if for some reason there is a lip or a tongue tie, like if that's not taken care of and you're not releasing some of those patterns, what could happen?
Mm-hmm. So a lot of babies, especially with posterior tongue ties, can figure out how to function, and they can go under the radar for a while, and a lot of times when we start to see issues is when they get older and we're starting to introduce solid foods, and we expect them to do certain things orally. We would expect them to make sounds and imitate different things, and they're not doing that. So a lot of times I would get those babies that are starting to show that dysfunction later on, even though they had no issues with breastfeeding. Later on, if we continue to have this issue not addressed, in older kids, what we're starting to see is mouth breathing, and that has just a tremendous effect on the facial orofacial complex and how the face grows, how the upper palate develops, and then what we see in older kids is their dentition. So all the kids who are in need of braces have some sort of myofunctional, I don't say disorder, but myofunctional implication that needs to be addressed. If that is not addressed, even though if we put them in braces and they go through the orthodontic treatment, that treatment is not going to last. They will relapse because of the functional muscle patterns that they're have been using for all these years to breathe, swallow, and chew food, and that is going to cause issues with that. If we don't address all that in children or teenagers, those people who then go into adulthood will have issues with, chronic mouth breathing will continue, and then that will then turn into issues with sleeping. Then later on in life, we, see people who have sleep apnea, and then that then leads into chronic conditions with the heart, and then we have diabetes and high blood pressure and all those chronic things that are being linked back to sleep apnea or dysregulated sleep patterns. So those are kind of, going through the lifespan of implications of not having that taken care of early in life.
That's crazy.
Yeah, it's definitely crazy. So many more things that you'd originally, not think about.
Yeah. So even adults can, it's never too late. It's just obviously it's going to take a little more effort, pre and post.
Right. Exactly. Yeah. So if you think about, for a baby, we're talking maybe weeks of, developed compensations. When we get to children and then adults, we're talking about years. So this is the work that we have to put in then to reverse all those patterns. And then even with release, then it takes, even up to a year to have all those patterns set back and reverse to a functional pattern. And it does take a lot of work, especially for school-age kids or even younger kids. It does take a lot of work for the parents, and then that takes a lot of commitment. So it is intense, but we've had success, and these kids then grow to be healthy and happy, and without any TMJ issues and sleep apnea and all those things that will happen if that is not addressed early.
You're preaching to the choir, because we, at our practice, we kind of focus on the little ones and the kids. So it's so much easier to, reset those patterns when they're young and it hasn't been, building up for so long versus the adults, because the adults, obviously we can help too, but it's going to be a little bit more involved just because, just like with that, they're setting those patterns early.
Right. Yeah.
Is there anything, just finally, like for the parents out there, like what would you say are some of the top things to look out for, or common symptoms of the buzzword, they call it TOTS, tethered oral tissues, so the lip and tongue ties? Like what would be a way that parents can be proactive and be like, okay, I have a concern, or it looks like this, and this is going on, maybe I should contact Margaret and get a further checkup?
Mm-hmm. So in infants, in babies, we're definitely looking at breastfeeding. If the mom wants to breastfeed and there are some challenges with that, that definitely is a red flag and warrants further kind of exploration of why that is happening. Even if we do go to a bottle and the baby is having a hard time, that can also be a red flag. Sometimes the baby will do well with the bottle versus the breast, but if any mom out there has attempted breastfeeding and hasn't been successful, there's definitely a red flag that we need to look out for. In addition, in babies, we look at open mouth posture. That is a huge red flag. No baby should be breathing with their mouth. They should be breathing with their nose all the time, unless they're eating or vocalizing later as they get a little bit bigger. But the mouth breathing is definitely a huge red flag. As we get these kids a little older, we're thinking about transitioning to different foods. So you start introducing solid foods, maybe foods that are mixed consistency, what we call them, things that have a little bit of a liquid and a little bit of a solid that they have to manage. And if the child is having trouble with that, that's definitely a warrants a further exploration of oral function. And then later in life, talking about proper development of speech, if they're delayed in speech, if we're having a hard time later accepting new foods, learning how to chew, learning how to eat and accept a variety of different tastes and textures. So definitely that is a concern. So the term picky eater is not only just because the baby chooses not to eat the food, but there might be something that they can't eat it, or you know they haven't had that sensory input that we need to have as a baby, and then therefore they're having some sensory aversions to a texture, taste, or whatnot. So definitely, if you see those things, you know those are red flags, and it's never too early to check. If I always say, if the mom is concerned, if something's in your gut's not feeling right, you're most likely right, and you should probably explore that and seek some professional help.
Wow.
Yeah,
Listen
I
to
hope
your
you guys
gut.
all caught that.
Well, thank you again so much for stopping by and doing this video with us.
Thank you so much for having me.
Yay.